Hello, friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. Okay, friends, we are switching gears. Welcome to episode 16. We are going to start a couple of episodes on anesthesia basics so that you, as a surgical student, can sort of understand what your colleagues on the other side of the drape are doing, or if you yourself are interested in the field of anesthesia, hopefully this is helpful for you. So the first thing that I want to talk about is the induction of anesthesia. So this is sort of the time from when the patient comes from wherever they come from to the operating room, to when they're asleep, to when you are starting your case. And so the first thing that I want to talk about, because we've had a couple of episodes about trauma, I thought it was important to talk about the different kinds of induction. So there's a standard induction, which is kind of be your scheduled surgery or even your emergent surgery or your urgent surgery, but not your emergent surgery, where you're going to go back and they're going to chat for a while and they're going to put you off to sleep and they're going to make sure that you're really preoxygenated, and that's awesome. There's another type called rapid sequence induction, and this is what's going to happen for a number of different kinds of patients. Rapid sequence induction, or RSI, is typically used in patients who potentially have not fasted and are an aspiration risk, patients who are having like emergent surgery, like trauma patients who have delayed gastric emptying, again, having that aspiration risk. Pregnant patients even can need RSI. And something that we have seen recently, and there's actually new guidelines out about it, is we talked about gastroparesis and delayed stomach emptying becomes really important because there's new data suggesting that patients who are on Ozempic, the GLP-1 medication, may have delayed gastric emptying. This drug has sort of a long half-life, and the way that patients receive it is they get an injection typically about once a week. And so the drug sort of sticks around in their system, and they get these injections once a week until they have sort of a steady state in their body. And so this is important to know because the new recommendations are suggesting that you advise your patients who are getting surgery to skip a week of their Ozempic before their scheduled surgery so that they don't have as profound of delayed gastric emptying. And so even if they have fasted all night long and not had anything to drink after midnight and all of those things, their bellies aren't still full. Because the reason we ask you to do that is not because we want you to be miserable, but because we don't want you to have some reflux or to vomit and then all of that go down into your lungs, because that can cause like an aspiration injury. It can cause aspiration pneumonitis. It can cause a pneumonia. It's just not a good idea to have food in your belly when you're trying to stick something into somebody's throat, because that can be really stimulating. So that is interesting to know. And also a little point that you can bring up, especially if you were on the surgery side, because this is like brand new guidelines, I think, in the summer of 2023, that it is recommended that you stop 7 days before surgery. There is some data out there. I read quite a few papers on this, and it's not necessarily 100% proven that the Ozempic is causing this. But I think anecdotally, people are seeing that maybe sometimes the bellies are fuller than they expect. And so one thing that some clinicians are doing, some anesthesiologists are doing before they take patients back to the operating room, is doing a bedside ultrasound of the stomach to see sort of how big it is. And then if the patient has fasted and their bellies are still full, they may consider doing RSI, or rapid sequence induction, for these patients. That was a long tangent, but I think that's really important to know, especially as more and more patients are taking that drug. And depending on where you are in the country, like for instance, where I am in the country, we really do deal with a lot of patients who are on weight loss journeys or have diabetes who are using Ozempic. And so this is good information to know if you are counseling patients for surgery, so even on the surgery side, but on the anesthesia side as well, to know that patients on Ozempic may have delayed gastric emptying. All that to say, RSI, we're talking about RSI, that's used in patients who have a higher aspiration risk, used in trauma. And the difference between that and standard induction is that RSI is much faster, and you also will probably not be bagging in between. So bagging is, if you're not familiar, where you have the face mask on the patient and then you're squeezing sort of the blue bag to deliver breaths to them while they are kind of asleep with the anesthesia medicine, but their paralytic hasn't yet set in. And we'll talk about all those different medications, but that is sort of the difference. Ideally, if you're doing RSI or you're doing standard induction, you want to pre-oxygenate the patient for a few minutes. And this sort of makes sense, I think, intuitively, but there's a little bit more to it. But essentially, in any patient, RSI or standard induction, you're going to want to have a nasal cannula on. You're going to bump their oxygen up, tell them to take some nice big breaths. If you've had surgery before, you may know that they even like place the face mask on and they're like, oh, smells like a beach ball. Like it's just oxygen, take some big deep breaths. And that is good for getting your oxygen saturations up. And of course, they want to maximize your oxygen saturations, but it's also to replace the nitrogenous air in your lungs with more concentrated oxygen, which just gives you a little bit more oxygen reserve and some time to intubate. That being said, when you're doing this, when you're pre-oxygenating, typically they're going to turn the oxygen up to like 100% for a little while so that you're receiving just 100% oxygen instead of the 21% stuff that we're breathing on a typical Tuesday. So you're going to have a lot of just like real fresh oxygen in your lungs and less nitrogen. And this, when you can measure this actually on the anesthesia machine, and with the special nasal cannula or with the face mask that they have on, you can see how much FiO2 you're getting back. And so if you target about 70 to 90% FiO2 return, which means what the lungs are seeing and then breathing back at you is about 70 to 90%. This buys you like 8 minutes of just like passive time. So especially if you're like, oh, we're going to have a difficult airway and this is a controlled scenario, you want to absolutely maximize your pre-oxygenation because this will buy you some time. Important to note, however, that while pre-oxygenation will buy you time, probably shouldn't take 8 minutes to intubate, but also patients who have pre-existing lung conditions, patients who have like morbid obesity and decreased compliance of their chest wall, or for some reason the capacity of their lung isn't very good, they have got fibrosed lungs, they just really can't expand them, they've got really bad COPD, those sorts of things. These patients are going to have less reserve. So even with pre-oxygenation, just like you would do in any other patient, these patients are going to have less reserve, which means you're going to have less time to intubate. So this is going to be really important to think about when you are making a plan for what things to have available. Obviously, in an ideal world, you would have everything that you need to intubate. You would have everything you need for backup intubation. You would know exactly who you're going to call if things don't go well, and you're going to have everything in the room for surgical airway if things do not go to plan. So, all that being said, the order that you typically give the medications to the patient. So we're going to talk about all these different medications, but there is like an anesthetic. So this is going to be the thing that sort of like drifts you off to sleep and you're not like aware of what's going on anymore. And some common medications that you can give for that are going to be like propofol, ketamine, fentanyl, etomidate, those sorts of medications. And again, we'll talk about them. And then there's a paralytic as well. And the paralytic is what's going to sort of like freeze your muscles. And some examples of that we'll talk about in this episode are going to be rocuronium and succinylcholine. So the order that you want to do this is you want to pre-oxygenate your patient. You want to give them the anesthetic before you paralyze them, because regardless of the patient and the emergency like situation, being paralyzed and being awake sounds really terrifying. And I think that they just try to avoid doing that to people. So pre-oxygenate, anesthetic, paralytic, and then you can intubate. The standard intubation compared to RSI, sort of last note about that, you're typically ready for intubation within 3 minutes of medication administration with a standard induction, but RSI, it's like 60 seconds. So it really does cut down on the time. You're not going to bag in between, like I mentioned, to like deliver those breaths of 100% oxygen. After the patient stops breathing on their own, you are going to just move to intubation once they're paralyzed, because also like bagging into their already tenuous, perhaps gonna vomit abdomens, you can blow air into their belly and that can just make things worse. And so you're not going to bag in between typically. Okay, let's talk about some induction drugs. And so these, first we're going to talk about our paralytics. I already mentioned them. We have rocuronium and succinylcholine. These are the two that I'm going to mention. There are other meds. There's rocuronium. There's different side effect profiles for these two or all of these drugs, but I'm going to talk about rocuronium and succinylcholine today. Apologies if I don't talk about your favorite one. So rocuronium is in sort of a class of drugs. There are two big umbrellas for paralytics. There's non-depolarizing agents and there are depolarizing agents. Rockaronium falls into the family of a non-depolarizing agent, and the way that this drug works is it competes with acetylcholine, so it inhibits muscle contraction, so it's a competitor, and that's how it sort of prevents you from using the muscle. This is a pretty standard drug, at least at my institution, and you can use this for standard induction or you can give a higher dose for RSI. Rockaronium isn't necessarily my first thought when I think of RSI, but people do use high doses of rock for rapid sequence intubation. And the cool thing about rock is with a standard induction dose, it's going to take like 3 minutes or whatever, but with the RSI, it can work as fast as 45 seconds. It typically does take a little bit longer. But the cool thing about rocuronium is it does have a reversal agent. The reversal agent is called Sugammadex. Sugammadex is kind of expensive, and so if you are going to do an RSI dose and give a ton of this paralytic, you're going to have to use a lot of the Sugammadex to reverse it, and so that's just something to keep in mind. And reasons why you would want to reverse it very quickly is if, oh my gosh, this airway is super difficult, we haven't preoxygenated, I can't bag them, like needing to reverse is a real thing that happens sometimes, and so that's probably like why rock doesn't come to my mind at first, but I have seen it been used for RSI before. It's used a ton in standard induction. Okay, succinylcholine is in the depolarizing family of paralytics, and the way that this works is it binds to postsynaptic acetylcholine receptors, and this triggers an influx of sodium and an efflux of potassium. So it binds basically like you need to contract, but then doesn't allow you to do it again. So you're sort of stuck in this purgatory of like muscles can't contract anymore. So it just makes all the muscles contract and then you can't use them anymore. And the reason we sort of like succinylcholine is unique in that it is depolarizing. And like I mentioned, it causes this efflux of potassium. And so that is really important to note because we know that potassium is mainly intracellular. And when we have too much potassium extracellularly, we are at risk for things like arrhythmia. And those arrhythmias can be really fatal. And so when we have patients who have a susceptibility to arrhythmias or patients who already have high K for some other reason, that's going to be something to keep in mind and a reason why you maybe would avoid using succinylcholine. And so some things to think about for high potassium are going to be like crush injuries. So if you're in a trauma, a patient has been crushed, burns can cause high K, pre-existing electrolyte abnormalities, tumor lysis syndrome, and then patients, interestingly, I learned this very recently, patients who have like significant motor deficits from a prior stroke or even a new stroke can be really sensitive to succinylcholine because the side that the deficits are on, where the muscles no longer sort of have their function, can have an upregulation of the acetylcholine receptors. And so when the succinylcholine binds, you just have an even higher response, and it can cause a lot of potassium release, which is not ideal. But when you use succinylcholine, you will see fasciculations where you will see like the muscles moving, and when they stop moving, you sort of like know you're ready for intubation. This is the most common thing I have seen for rapid sequence induction, even in trauma patients, because you can treat hyperkalemia. You can't treat a patient who is no longer breathing or has a heartbeat. And so I think that's sort of like the rationale that I have heard, but also I think we would maybe use a different drug if we knew the patient was super hyperkalemic. Again, this works super quickly and is good for RSI. It does not have a reversal agent. This works in about 30 to 60 seconds compared to rocuronium, which can take about 3 minutes to work. You will again have those fasciculations due to the depolarizing nature of the drug. And then this wears off in about 5 to 15 minutes depending on the source. And so this is sort of fast on, fast off, whereas rocuronium lasts about 55 to 80 minutes from the last dose, so you'll definitely need a reversal agent if you are running into trouble. Whereas if you just need a bag for 5 minutes, that is a different story with the succinylcholine. So those are two paralytics that are pretty common. Now we'll speak sort of about the anesthetic drugs, those induction drugs that we talked about. We're going to cover propofol. We are also going to talk about ketamine, etomidate, a little bit about fentanyl, and a little bit about Versed. So speaking about propofol only causes hypnosis, so it doesn't necessarily have any effect on your pain, but is very commonly used in the OR. I saw it used today on some endoscopies and colonoscopies that I was helping out with. Propofol very commonly causes hypotension, so causes a ton of vasodilation. Patients oftentimes will need some treatment for the hypotension that they get from propofol if they're starting low. And so that's something to look out for as you're watching sort of the induction process. They may give them some phenylephrine, they may give them some ephedrine, just sort of depending on the patient's clinical picture. That is a story about propofol. It can feel, we call it spicy in the IV, but it can kind of burn in the IV. It is a medicine that causes some pain when it's going in. Some patients will receive lidocaine before they receive the propofol, and that can sort of help to ease the pain of the propofol and make it a little bit more comfortable. But this can help them go to bed. As far as the metabolism, it is hepatically and extrahepatically metabolized. Some things that propofol does is it can decrease cerebral perfusion pressure and ICP. So this propofol can actually be used outside of the OR and often is for patients who are having like extremely high intracranial pressures, who they're having a really hard time controlling their ICPs, even with ICP monitors, even with EVDs. Patients can be put on propofol in order to sort of like cool them down until we get them into a more stable position. So that is one sort of useful side effect of propofol. It can also be used for refractory seizures. So if patients aren't responding to interventions for status epilepticus, you can use propofol and kind of put them to sleep, and that can help. You can also use it for long-term sedation, but there are risks. So one big thing that you want to think about when you're thinking about long-term sedation and using a lot of propofol, even like a moderate amount of propofol for a couple of days in susceptible patients, is propofol infusion syndrome. The things that are going to clue you into propofol infusion syndrome are going to be metabolic acidosis, rhabdomyolysis, kidney failure, and hypertriglyceridemia. Something that I felt so silly for not knowing sooner is that propofol is a lipid emulsion. Like, the medication itself is dissolved in lipid. Okay, so you are directly delivering triglycerides to this patient, and so you probably, especially if you're using this for long-term sedation, you're probably going to be checking their triglycerides, and there comes a point where your triglycerides get high enough that you're at risk for a little thing we like to call pancreatitis. And pancreatitis can be really devastating, especially if it's like a hemorrhagic pancreatitis. There's all sorts of ways that your pancreas can go crazy. You have all these fluid shifts and you're already unstable. Something that you don't want is pancreatitis. You also really probably don't want metabolic acidosis, kidney failure, or rhabdo. So propofol infusion syndrome can be really devastating. And some other clinical features of propofol infusion syndrome are going to be like arrhythmias. You can have hepatomegaly, you can have hyperkalemia, and start to have some like cardiovascular collapse even, which is pretty scary. There are some risk factors for this. I think the biggest ones are receiving a lot of propofol for a long period of time, but it can make it worse if you are already really sick. So like patients who have trauma, patients who are septic, patients who already have pancreatitis, or patients with severe TBIs as well. Some other factors are if the propofol dose is greater than 4 mg per kg per hour, if the propofol infusion is happening for more than 48 hours. Those are just some things to think about. So if you, as a medical student, are making plans for your patients in the ICU and you know that they've been on propofol 5 mg per kg per hour for a day and a half, and they're pretty deep, you could maybe say, hey, I know that propofol related infusion syndrome is a thing. what do we think? Like, what's our plan with this patient's sedation? How long are we going to do this? If we're going to continue doing this, should we check their triglycerides today? Like, I think those are things that I maybe didn't know to think about when I first started in the hospital. And so get a leg up on me, start thinking about propofol infusion syndrome. Like, no drug, something just to know is that no drug, no medication, no injection, nothing that you do to a patient is ever without risk. Okay, so it's important for you to consider that even the most benign of things, like thinking about a pulse oximeter, those like sticky ones, even that can harm a patient. I have seen patients who had their pulse oximeters on and somehow it got ripped off and it pulled the skin off with it. And this patient had to have another surgery to like reconstruct their finger, and it was just a whole thing. So just know, as you're going into medicine, everything you do can have a negative consequence. So the sooner that you sort of like grasp the like basics of how things are working, you are going to start to think about, okay, what could go wrong? How can I prevent that? How can we optimize this patient? I think that starts to be like a really cool part of medicine. And I think that I'm just now starting to enter it. And so I hope that I can bring you with me and we can learn these things together. But that's my soapbox about thinking about how these things impact the system, how they impact the patient, what are the risks, instead of just being like, I understand the science, I understand why we're doing this. Start to think deeper about those things. Okay, anyway. That was a lecture. I apologize. Let's move on to ketamine. So ketamine is a drug that's really helpful that can help with pain and hypnosis. Hypnosis, I use the term lightly. Some patients can have hallucinations on ketamine, so you compare it with like a benzodiazepine that can help sort of like allow patients to not be forming memories of that time because they can be like pretty severe hallucinations. The reason why ketamine is a good choice in patients who are super unstable, the reason why, if you were to ask me, a lowly fourth-year medical student, what I would do for rapid sequence induction, I think I would choose ketamine in some situations because it does not cause respiratory depression, but also it can increase your blood pressure, it increases your heart rate. And so those sorts of things in a patient who's kind of crashing, who has a low blood pressure already, we're about to cause some positive pressure in their chest. I really don't want to be giving propofol to a patient who has I don't want to be giving an induction dose of propofol, I should say, to a patient who has a blood pressure of 80/50 because that's going to tank their pressures. I'm going to add positive pressure into their chest, and now they're going to have absolutely no venous return to their heart, which means they're going to be having absolutely no blood flow to their body, and they're going to be at risk for like a hypoxic arrest or like cardiovascular arrest. Just not ideal. Okay, so thinking about when you would use these drugs is also important. So ketamine can increase your blood pressure, increase your heart rate sort of on induction, and it can help with pain and hypnosis. But mostly I would choose this for those reasons. If your patients are pretty unstable, ketamine is a safe choice. It releases catecholamines, and that's sort of the mechanism by which it causes the increase in the blood pressure and the heart rate. A quick side note about ketamine is that it can increase your secretion. So if you're going to use ketamine, need to have your suction ready, and you can pair this with something like glycopyrrolate to kind of dry those secretions out so patients aren't aspirating or doing crazy stuff with their secretions. Etomidate is another option that you will hear about. Etomidate is hemodynamically neutral for the most part. So again, this is a good choice for patients who are hemodynamically unstable. One thing about etomidate, it's like the most likely of the three that I mentioned to cause nausea. And so thinking about that, if you need to use etomidate for any specific reason, making sure that you're thinking about like a scopolamine patch or Zofran, or checking in with that patient, talking to the PACU nurse, making sure they know that like nausea is possible in this patient. Another common side effect that you'll hear about etomidate is that it can cause adrenal suppression. And so this is very important to know and to communicate with your team, because intraoperatively, if you needed to use etomidate for any reason, or etomidate is a thing that your center uses, and now for some reason you're just having like blood pressures that aren't responding to things, or for some reason now the patient's just tanking and it doesn't make any sense. If you gave etomidate and they're having some adrenal suppression, you may need to give them some stress dose steroids to sort of boost them up. that may be something that you need to consider. Another fun fact, sort of tangent on stress dose steroids, when you are thinking about preoperative evaluation of your patients, even you surgery folks, even you anesthesia folks, if you're seeing patients before surgery, recommending surgery, evaluating for surgery, etc., if patients are on long-term steroids, sort of over the 5 milligram cutoff, you should be thinking about if the patient is going to need intraoperative stress dose steroids. And there are like lots of guidelines for this, so we won't get into the weeds about this, but it is important to note that if you see a steroid on the medication list, like let's say the patient has psoriatic arthritis and they take prednisone occasionally, maybe ask them, for how long have you been on the prednisone? When was the last time that you took a long course of it? That is important to know when you're heading into the operating room, even for just a short case. Last couple things, I want to talk about fentanyl very quickly. Fentanyl can be used for pain. It works really fast, but it does decrease the respiratory drive. We use this a lot of times in the trauma bay. Fentanyl is given as a controlled substance. It is safe to use in the hospital because we know what the dose is. Fentanyl is like pretty commonly used, and so it's important to know that that is an option. It works fast. It's fast on, fast off. Can make people kind of sleepy though, and you can reverse it with a little naloxone. Midazolam or Versed is also a good option for patients, especially like I mentioned, if you're going to be giving ketamine and you have it available and you have the time, can help with some anterograde amnesia. So these patients are not like forming memories of what's happening to them in the OR, or if they are having these hallucinations with the ketamine, it can help with that. I very briefly mentioned these, and so I just want to talk about them really quickly. Some reversal agents, so Sugamidex is the one that I mentioned before, and this is for reversal of rocuronium. So the dose of the Sugamidex, in case you get asked about this, I don't know why you would, but just so that you know, is based on how many twitches the patient has. So oftentimes intraoperatively, we will monitor the twitches. Patients have to sort of know how deep they are under sedation. And so if they have no twitches, this means that you would give them like the highest dose of Sugamidex. If they have 3 to 4 twitches, you would give them the lowest dose. And then anything in between, like 1 to 2, you would give an intermediate dose. So based on sort of like how awake you are, and they are going to monitor that with the twitches. This causes a pretty fast reversal, but it can also cause bradycardia. Some patients are allergic to Sugamidex, so something to keep in mind. And then another fun fact, especially if you are operating on patients in their reproductive years, it can inhibit birth control for 7 days. So patients who are having surgery need to be counseled on this so that they don't accidentally get pregnant in the 7 days after their surgery because you use Sugamidex. So patients need to know about this. Make sure you tell them, so that you don't accidentally cause patients to have babies when they're not ready, or go through the stress of dealing with that at this time until they're ready to choose that for themselves. Another thing is that Sugamidex is renally excreted, so it may not be the right choice in end-stage renal disease, but use your clinical judgment. The reversal agent that I was talking about, I lied to you. Well, I kind of did. Neostigmine is what has been used in the past for Sugamidex reversal. It takes about 15 minutes, so it's less helpful. I mean, it's still helpful, but it still does take 15 minutes. You can't use it if you don't have any twitches, so you do have to sort of get the patient to where they're awake enough and weaned enough that they have some twitches, and so the neostigmine is less useful for that. You also need to give it with an antimuscarinic because it's an acetylcholinesterase inhibitor, but it also causes some crosstalk with the muscarinic receptors. So you should give an antimuscarinic like glycopyrrolate or atropine to help avoid bradycardia and bronchospasm. Okay, that's a lot of information, but I think this is like a good introduction into like what happens at the very, very beginning of surgery, and hopefully some fun facts to spur some discussions. I think as a medical student on surgery or on anesthesia, it is awesome for you to be in the OR early, to be with your patients, to be asking anesthesia questions, even if you are on the surgery side, because if you want to be a surgeon, you're going to be working with them, but also they might let you put in an IV. They'll show you where the leads go. They'll tell you all about the monitors. Like, it's important and it's useful and it's interesting stuff. And I encourage you to ask questions because your anesthesia colleagues are super nice and usually very, very happy to help. And that's it. That's all I have to say about this episode. I hope that you enjoyed it. I think this was like a chock full episode, and I'm really happy with all the things we talked about. And I hope you have a lovely day, and I'll talk to you next time. Bye. That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.